Breathing is an essential function of life, as every system in the human body requires oxygen to function properly. Acute respiratory failure is a disease process which impacts breathing and may lead to sudden and adverse health consequences such as tissue and organ damage. According to a national survey in 2017, there were over 1.1 million patients diagnosed with respiratory failure, accompanied with an average length of hospital stay of 10.5 days. As recent advancements in medicine gradually improve patients with acute respiratory failure, our treatments could only be as good as our diagnostics, which include invasive and non-invasive monitoring. This video will discuss the pathophysiology of the disease, related signs and symptoms, risk factors, diagnostics, and treatment options. We will also relate it to my patient ML's hospitalization. ML is a 68-year-old female patient who was admitted to the med-surg unit for acute respiratory failure. ML has a history of COPD, GERD, chronic heart failure, hypertension, and diabetes. The patient's chief complaint was shortness of breath. Breathing was the number one priority since past medical history involves COPD, and due to the fact that she's currently complaining of shortness of breath. On the day of care, her vital signs at 7:30 were a temperature of 97.2, which is slightly low, a pulse of 94 beats per minute, a pulse oximetry reading of 94%, SpO2, which are both normal limits, which are both normal values, but we have to keep in mind that the patient is currently on 3 liters of oxygen therapy. Her respirations were at 20, which could be considered high, but since she has COPD, this can be expected. Her blood pressure was at 113/80, and she noted zero pain. All right, so let's go. As I walked into the room at 8 o'clock to perform a head-to-toe physical assessment, I noticed ML's shortness of breath right away. I asked a series of short questions and completed a physical examination for her neurological and cardiovascular assessment. ML showed shallow respirations and diminished breath sounds as I auscultated her lungs. ML had active bowel sounds with soft, flat, and non-tender abdomen, displaying normal abdominal findings. She also had no visible joint deformities and had equally strong push-pulls for both her upper and lower extremities. All the while she confirmed she uses a front-wheeled walker as an assistive device for mobility. Acute respiratory failure occurs when there is an inadequacy within the respiratory system's gas exchange process. Gas exchange entails O2 and CO2 transfers between atmospheric air and circulating blood in the pulmonary capillary beds. As the patient breathes in O2, they breathe out CO2. When one of these gas exchanging functions is inadequate, it may result in acute respiratory failure, either being classified as hypoxemic or hypercapnic. Hypoxemic respiratory failure is when there isn't enough oxygen in the blood, while the CO2 levels remain near normal, while hypercapnic respiratory failure is when CO2 levels are too high while oxygen levels remain near normal. The most common cause of hypoxemic respiratory failure is ventilation perfusion mismatch. The ventilation perfusion ratio compares the volume of blood that's perfusing in the lungs every minute to the amount of gas that reaches the alveoli every minute. This is typically a 1-to-1 ratio, as there's 1 millimeter of air for every 1 millimeter of blood flow. Conditions that present increased secretions in the airways, such as COPD or pneumonia, are common culprits for this mismatch. ML's history of COPD make this more than likely to be a contributing factor for acute respiratory failure diagnosis. Hypercapnic respiratory failure occurs when there is either increase in CO2 production or a decrease in alveolar ventilation. There are many different diseases that could cause the limitation in ventilation, such as airway abnormalities, central nervous system abnormalities, chest wall abnormalities, and neuromuscular conditions. There could be a variety of causes, including conditions that make it difficulty to breathe in, such as collapsed airways, obstructions, conditions which make it difficulty to breathe out, such as narrowed airways due to asthma and fluid buildup in the lungs, caused by pneumonia or heart failure. This relates directly back to ML, as she has history of CHF, so it may be likely that it caused fluid backup in the lungs, resulting in shortness of breath. Symptoms may depend on what type of respiratory failure it is. If related to hypoxemia, the symptoms may include drowsiness, shortness of breath, extreme dyspnea on exertion, and cyanosis. However, if related to hypercapnia, the symptoms may include blurred vision, confusion, headache, and rapid breathing. For diagnostics, a physical examination by auscultating the lungs would check for rapid breathing or abnormal sounds, while auscultating the heart to check for arrhythmias and looking closely at the skin to monitor for cyanosis. ML's lungs presented with shallow breath sounds, which was the first abnormal finding that hinted towards pulmonary edema. Diagnostic tests and labs would include pulse oximetry to check O2 saturation, arterial blood gases, also known as ABGs, to assess oxygen, carbon dioxide, pH, and bicarbonate. And we could also do chest x-rays to determine what may be causing the shortness of breath. Treatment for acute respiratory failure often includes a combination of respiratory therapy as well as drug therapy. The major goals of respiratory therapy are to maintain adequate oxygenation and ventilation, while drug therapy is to relieve bronchospasms, reduce airway inflammation, and help treat pulmonary infections. Respectfully categorized as bronchodilators, corticosteroids, and antibiotics. ML was on oxygen therapy for the duration of her hospital stay to ensure adequate oxygenation. She continues to use this at home as well. Oxygen therapy methods may depend on how severe the respiratory failure is. Simple nursing interventions for ML to help with respiratory failure would include repositioning, ensuring adequate hydration, encouraging ambulation, and the use of incentive spirometer. Acute respiratory failure is a complex condition to manage and to treat, especially considering ML's age. This disease can often have a sudden onset without any warning, so it's vital to receive medical attention promptly. Thank you.